Alright, so now we're up to the Otology section. We finished Neurology. Otology is a really tiny section. There isn't too much to it, but you do get questions from practically everything that's in this little section. Like, it will be on your step 1, guaranteed. You're going to have a question on auditory physiology. You're definitely going to have a question about the Weber test or the Rinne test being applied. And then you do have a chance of having a question on presbycusis and cholesteatoma. I've also added a little more because that's all, in first aid is pretty much just one page and then they talk about vertigo. But I've added a little bit more that came from UWorld, a little more about the cranial nerve anatomy and the physiology of hearing and the organ of Corti, and then we have some practice questions as well. So I'm going to go into that. But what I do want to urge is if you're following this playlist from beginning to end, then throughout the playlist at different times I've told people, go back and review X today, go back and review Y today, stuff like that. I do urge that you go back today after finishing otology and review the pathway of the tracts, the neuroanatomy tracts, right? Know the corticospinal tract, dorsal columns, and the spinothalamic tract, where they decussate, what parts they go through, right? And then your sensory tracts. They have a part in the thalamus. They use the VPL. There are things that use the medial meniscus. You should really know those parts, right? The corticospinal tract uses the pyramids. Know all of that because you get various questions about different parts of different tracts, all right? So that's really important to revise regularly. On top of that, I would also ask you to, at the same time, revise the pathologies, right? And it's all done in one video for me. I talk about the pathology of those tracts in the same video. So your medial medullary syndrome and all of that stuff. Make sure you know how those guys present because those are often just giveaway questions if you remember. So here, the first thing we're looking at is auditory physiology, right? So the breakdown of the outer ear, the middle ear, and the inner ear. So the outer ear is literally what you can see. So the visible portion of the ear, which is the pinna, includes the auditory canal and the tympanic membrane. Transfers sound waves via vibration of the tympanic membrane. That's all that thing does. The middle ear is air-filled space with 3 bones called the ossicles, the malleus, incus, and stapes. Ossicles conduct and amplify sound from tympanic membranes to the inner ear. Now, these ossicles are often mentioned over and over, more so in relation to the embryology, right? So if you go to reproductive, right, in reproductive embryology, you're going to see the development of those guys, the different bones in the ear. And it's really important to remember that, right? Because this page, the pharyngeal arch derivatives, and then the page after that about your pharyngeal pouch derivatives, these are things you definitely want to make sure you have down. And if you look at this image here, you can kind of see, right, a lot of the developmental stuff. In this image over here too, you can see the stapes, right, coming from the pink arch 2, and the malleus and incus related to the green stuff, which is all arch 1. Right, so these images, when we get to reproductive, we'll see it again. These images do a really good job kind of visualizing it for you, color coding it for you, so it's really helpful in that manner. Alright, so your first pharyngeal arch is the one that's able to give you your, where is it? Did they not list it here? Oh, sorry, the first one doesn't give you anything, my bad. Where was I? The green stuff was the second one, right? What was I saying? No, arch 1 is green. Arch 1 is green, arch 2 is the pink stuff. What are they talking about here? Oh yeah, okay, my bad. Yeah, it is here. Malleus and incus, right? Your first pharyngeal arch gives you the malleus and incus. That was the green stuff in this image right here. In terms of bone, up here they're showing you the muscles that the various arches give you. Down here they're showing you the various bones that the arches give you. Right, so the green stuff is all your muscle and bone over here from arch 1. The pink stuff is every muscle of your face, you can see. And these bones over here from arch 2. Right, so arch 2, you can see you have your stapes. Alright, so that's the only guy that's a little separate. Malleus and incus come from the first pharyngeal arch. Stapes come from the second pharyngeal arch. You can get weird questions about that kind of embryology as well. And embryology doesn't have its own per se chapter, right? It's divided in every chapter, right? You have the embryology of every single organ separately. So you want to make sure you always visit those embryology sections as you study things. You should know where they come from because oftentimes you can get a question and you might know the answer is stapes, but your answer choices might not have stapes. It might be like a derivative of the first arch, a derivative of the second arch, etc., etc. You should know that answer just based off of that relation. These ossicles conduct and amplify sound from tympanic membrane to the inner ear. All right, so these bones are pretty much the sticks that are responsible for playing the drum, and you won't be able to hear well if these bones are not working, or if they're broken, or if they get moved from where they're actually supposed to be. Another thing we're going to see is hyperacusis. That's also going to be related to one of these ossicles, because remember, these guys are here to amplify sound. Right, so if something can go wrong with them, they might amplify too much. The last part is your inner ear. This is the most important one. So the inner ear has this snail-shaped, fluid-filled cochlea, which does look like this, contains the basilar membrane that vibrates secondary to sound waves. Vibration is transduced via specialized hair cells, and those hair cells convert those vibrations into auditory nerve signals that then go to the brainstem, and you hear that as sound. Each frequency leads to vibration at specific locations on the basilar membrane. Low frequency is heard at the apex, near the helicotrema. So that's going to be wide and flexible low frequency sounds, right? And we've all heard what low frequency sounds like, and high frequency is a very squeaky sound. So high frequency is heard best at the base of the cochlea, and it's going to be thin and rigid. So they're describing where the sound is. And over here we can see what they're talking about, right? So the apex, right near the helicotrema, is all the way in here. So you can see how this is going to be your low frequency area, 200 hertz, 400 hertz, 600 hertz. Those are lower frequencies, right? And right here in this description, you can see right here, right? See, this is the low frequency stuff at the apex, all the way at the apex. You're hearing it deep in the apex. Your high frequency sounds, which can go up to 20,000 hertz, those are heard at the base. Right, so right at the beginning. So the deeper or the low frequency is often called a deep voice, right? So when you have a deep frequency or a very deep voice, the deeper the voice is, the deeper it goes in your cochlea. That's how I memorized it, right? So it's a great way to think about it like that. The deeper the person's voice, the deeper in your ear it'll go. Right? Whereas if you have a high frequency voice, a high frequency squeaky voice, you don't call that a deep voice. The squeaky voices are going to be right at the base of your ear, and that's why you almost always just hide your ears if someone is screaming with a very squeaky voice. So I repeat the embryology stuff here too, right? So for revision purposes, remember that the malleus and incus come from the first pharyngeal arch, along with the tensor tympani, muscles of mastication, maxilla, mandible, and cranial nerve 5, right? 5.3. The stapes comes from the second pharyngeal arch, along with the stapedius, styloid, lesser hyoid, and cranial nerve 7. So those cranial nerve relations and all of that is stuff that you can try memorizing in one good sitting, but it's always good to keep repeating it. The more times you see it, the better you get at it. So that's your auditory physiology. The next thing here is diagnosing hearing loss. Everyone has had at least one question where the Weber test and the Rini test was used in the question stem, and then even after reading the question stem and understanding the results, it was a little difficult to figure out what kind of hearing loss the patient had, right? You got to really practice that and truly understand what these two tests are doing, because they're not the best tests, but they are cool because of the way they work, so it's often tested. So you have two guys. You have your Weber and Rini. Let's take a look at how they work. The Weber test, you take a vibrating 512 Hz tuning fork and place it in the middle of the forehead or on top of the head, equidistant from both ears, right? So you would put it right here or right here somewhere, equidistant from both ears. The patient will report in which ear the sound is louder. A normal Weber test has a patient reporting the sound heard equally in both ears. In an affected patient, if the normal ear hears sound better, there is sensory neural loss on the other ear. Okay, so how are we diagnosing anything off of this? Okay, so basically you take your tuning fork, you vibrate it, you put it in the center. I should be able to hear it in both ears just fine. Keep in mind that air conduction is better than bone conduction, right? That's the normal thing. Air conduction is better than bone conduction because we all hear each other through air anyway. So when you put it in the middle on the forehead right there, right, you're hearing two things. You're hearing the bone conduction because it's touching your skull, but you're also hearing the tuning fork in both ears from the air conduction. If you can hear in one ear that it's louder, that means that the other ear, right, has your sensory neural hearing loss. Right? In an affected patient, if the normal ear hears sound better, there is sensory neural loss on the other ear. Now, if you look at what they're telling you here, Weber test, in normal hearing, there should be no localization because you can hear equally in both ears. If you have conductive hearing loss for any reason, it's going to localize to the affected ear. But if you have sensory neural hearing loss, it's going to localize to the unaffected ear. Either way, it's the same ear. Right? You can tell how the sound is localizing to the same, practically the same ear. So what you're going to notice, though, however, from this explanation, that it's still pretty unclear. How am I supposed to know, is it sensory neural loss or is it a conducting loss? Like which problem do I have just by doing the Weber test? So you kind of can't. You can't really know it just by doing the Weber test. So then you do the Rinne test too. So how does that one work? That one, you take a 512 Hz vibrating tuning fork and you put it on the mastoid bone and ask when the sound is no longer being heard. Right? So you put it on the mastoid and you try to listen. The patient tries to listen, and when they tell you they can't hear it anymore, then you take the same fork while it's still vibrating. You don't re-vibrate it, right? So take it the same way, and then just hold it near the auditory canal and ask if they can hear the sound. If they are unable to hear the tuning fork after the mastoid portion of the test, their bone conduction is greater than the air conduction. It just makes common sense, right? Because when it was touching the mastoid, they were able to hear it. Then when you put it near the ear and there was no more physical contact, they could not hear it. So they're saying that their bone conduction is better than their air conduction. That's how you localize this one, and you know that they have conductive hearing loss. Alright, so you have to be careful. This is the thing you want to look for in a question. If they give you this, it's an easy question. It's an easy version of the Weber-Rinne hearing loss question. So the physician will do the Rinne test. They'll tell you that they put the ear on the right mastoid. Sorry, they put the tuning fork on the right mastoid. Then they put the tuning fork next to the right ear, and the patient could not hear it. That means that you're thinking they have conductive hearing loss on the same right ear because they couldn't hear it well, right? And you would now do the test on the other ear. It shouldn't happen there. And you do the Weber test, and you can figure out it should localize to the same affected ear again, the same ear where they could not hear the air stuff anymore, and you know, right? So I wrote here, then whichever ear the bone hearing is better than air has some issue. Weber will probably lateralize to the same ear where the bone is better than air occurred. Right, so on my right ear, when you put the tuning fork here and I couldn't hear it anymore, now when you do the Weber test, I'll tell you that I hear it better on my right ear because Weber test uses the bone, right? So I can hear it through the bone really, really well, but I can't hear through the air that well because I have conductive hearing loss. There's something in my ear canal that's not working too well. When you do the Rinne test and you try to diagnose sensory neural hearing loss, it's a little harder because it's going to be bilateral. You're going to have reduction bilaterally, right? Air is better than bone, which is, normal, but the reduced sound bilaterally, they're going to tell you they can't hear it better on either ear. When you put the tuning fork away from the ear, on either ear, they can't hear it better. Right? So it's a very confusing thing the first time you learn this stuff. But you have to really, if you have a tuning fork, you should try it out, see how it feels, and then you start getting a better idea of what the patient is experiencing. So really try it on yourself. Like, take the tuning fork, vibrate it, put it on your forehead, put it on either ears. Try to understand what's happening with the patient, and then you start seeing what's being diagnosed with each test. Right? So the Rinne test, I always think of it as the ringer. Right? Can you hear the phone ringing? That kind of thing. So the Rinne test is all about checking whether your air conduction is better than the bone, right? And if it's not, then you know that there's a conductive hearing loss issue, and you work with that. You confirm it with the Weber test. I do have a practice question here that kind of works with that, and it does help. But just keep in mind as you're reading the question, try to really imagine you are the physician doing this test, right? So it's the lower question here from UWorld. Tells you that a 54-year-old woman comes to the clinic due to difficulty hearing for the past few weeks. During the neurologic exam, the physician assesses her hearing using a vibrating tuning fork. So you immediately know Weber and Rinne tests are about to pop up. The handle of the tuning fork is placed on her left mastoid process until the sound is no longer audible. The tines are then quickly placed near the patient's left auditory meatus, and she reports hearing no sound. So this is the Rinne test, right? She can't hear the phone ringing. That's how you want to think about it. So they're doing the Rinne test. So on her left ear, on the mastoid process, she was able to hear it, but as soon as they put it near the ear with no physical contact, she could not hear it. So that sounds like a conductive hearing loss on the left ear. When the handle of the vibrating fork is placed on the middle of the forehead, so now they're doing the Weber test, she hears the vibration more strongly in her left ear than her right, because when you put it on the forehead, you have that bone conduction happening again, right? There's physical contact. It's working fine on the left ear. So everything lateralized to the same ear, that is a conductive loss in that left ear. See, this was a really good question, doing something we just talked about. This is kind of what you're really hoping you get, all right? This is what you really want to get. You want to get a patient where they did the Rinne test and they couldn't hear it anymore when they just held the tuning fork away without physical contact. If you can't hear the tuning fork without physical contact, that means you don't have air conduction. Air conduction is not working. You might have a lot of gunk in your ear. You might have some kind of damage to some part of your ear, something like that. But that's not sensory neural. Sensory neural, I don't have a practice question here for sensory neural damage, but if you have a sensory neural hearing loss patient, right, then notice with the sensory neural hearing loss, this is how the story is going to look like. You'll do the Rinne test on this ear, and they'll tell you they can't hear it. They'll do the Rinne test on the other ear, and again, they'll tell you they cannot hear it without the physical contact. So it's reduced bilaterally. Then you'll do the Weber test, and they'll tell you that they hear it a little louder on one ear, right? Localizes to the unaffected ear, right? So that means that if they hear it louder on the right ear, that's because the left ear has sensory neural hearing loss, right? So it's a little more difficult, but it's a story that you can form. You can make up your own practice test question if you want to and just memorize that question. Or if you have a practice question with sensory neural hearing loss as an example, then feel free to email it to me. I'll add it into the book, and then just use that as your thing to memorize that concept, right? Because it's not that bad. It's a nice question. It's almost 100% chance that you're going to have it on your step one, and you definitely don't want to mess it up because there's not much physiology or any of that involved here. It's very mathematical because it's a very systematic test. The next thing you have are types of hearing losses. You can either have noise-induced hearing loss because you have a job where there might be really, really loud music or something, or you have presbycusis. Presby means aging. In New York, there's a hospital called the New York Presbyterian. Presbyterian is a hospital that works really well with geriatrics, right? Older patients. So presby anything is something aging related, right? So presbycusis here is aging related progressive bilateral symmetric sensory neural hearing loss. Sensory neural, right? Often of higher frequencies because the higher frequency stuff is right at the beginning due to destruction of hair cells at the cochlear base, and the base is where you hear the higher frequency stuff. They'll have preserved low frequency hearing because the apex where you have the helicotrema, right, deep voice goes deep into your apex and you're able to hear that just fine. But they can't hear the shrieking, acute voices, right? Noise-induced hearing loss, you're almost always going to get a question about a guy who either works at an airport and doesn't wear his headphones or works as a DJ or something like that, and they're unable to hear voices that well now. So that's actually damage to the hair cells in your organ of Corti. So now you have loss of high-frequency hearing first, and then eventually you're going to lose the deep hearing as well. Sudden, extremely loud noises can produce hearing loss due to tympanic membrane rupture as well. That's another thing that can happen. All right. So it's really often a question about someone's job, what they do. Okay. The last thing on this page is a Cholesteatoma. So this is an overgrowth of desquamated keratin debris within the middle ear space, and that's what you're seeing right there. May erode the ossicles, and you can have mastoid ear cells leading to conductive hearing loss. Right? So the same patient here that was presenting with conductive hearing loss, where they couldn't hear the air well because there's no conduction, they can be due to this kind of stuff, right? They might have too much gunk in their ear, they can't hear stuff. Often presents with painless otorrhea. Shouldn't be painful at all. It's not an actual tumor. Then one thing you want to make sure you remember is when a patient comes in with any gunk in their ear, you don't clean it, right? You don't go ahead and clean it. You don't do it unless the patient really requests you to do it, or you feel like you really need to, right? And even at that point, you would ask them first. But it's not advised to go ahead and clean out a patient's ear if they're not asking you to. So don't do that. Just keep that in mind. It's a little step 2 CS thing. It's also a thing that's just clinically relevant. It does happen. So we have a couple more questions. This one here in the middle is an AMBOSS question. This says, a 39-year-old man comes to the physician for evaluation of hearing loss. He reports difficulty hearing sounds like the beeping of the microwave or birds chirping, but can easily hear the pipe organ at church. So again, beeping of microwave and birds chirping, those are very squeaky sounds, right? So those are high frequency sounds, whereas the pipe organ at church, that is a deep sound. That's a very low frequency sound. So this looks like he has injury to the base of the ear. He works as an aircraft marshaller. A Rinne test shows air conduction greater than bone conduction bilaterally. Right, so this is an example of what's happening here, right? This stuff, reduced bilaterally, air better than bone, right? That's exactly what we're seeing here. So a Rinne test shows air conduction greater than bone conduction bilaterally. A Weber test, however, does not lateralize. If the Weber test did lateralize to maybe the left ear, that means that this patient would have right ear sensory neural hearing loss, just to give you guys context. However, in this question, the Weber test did not lateralize. What is the most likely underlying cause of this patient's condition? So since the Weber test didn't lateralize and the Rinne test was bad bilaterally, this patient seems to have actual damage to the ear inside, right? And you can see from the job this person does, aircraft marshaller. So aircrafts make a lot of noise, and it looks like he had destruction of the organ accordion. That is the answer. Another question had the same case, and the answer was damage to the basal turn of the cochlea, right? Because, of course, the base is where you hear high-frequency, squeaky sounds, okay? So that was all given in the question. Really well done. You could read the rest of the explanation if you want, but the question was pretty straightforward. You just have to know your stuff so you can actually derive information from the stuff given in the question stem. The next question here, this one's from UWorld. 34-year-old man comes to the clinic with a 3-week history of difficulty hearing. He finds it increasingly difficult to tolerate everyday sounds. He also complains of ear pain and often avoids public places as a result. The patient has no past medical history and takes no medications. Injury to which cranial nerve is most likely responsible for his condition? And then facial and trigeminal were both answer choices, but the correct answer here was the facial nerve. The middle ear cavity contains 3 auditory ossicles, the malleus, incus, and stapes, and 2 skeletal muscles, the tensor tympani and the stapedius, that participate in transmission of sound from the tympanic membrane to the cochlea. The stapedius arises from the wall of the tympanic cavity and inserts on the neck of the stapes. That's the muscle. It is innervated by the stapedius nerve, a branch of the facial nerve. The stapedius muscle functions to stabilize the stapes. Paralysis of the muscle causes the stapes to oscillate much more widely, producing hyperacusis. And that's what this patient has. Everything is sounding way too loud to him. Ipsilateral hyperacusis is often associated with Bell's palsy, where you have ipsilateral cranial nerve 7 involvement. All right. So cranial nerve 7, as we just said, right, the stapes comes from the second pharyngeal arch, along with the stapedius muscle, the styloid, and the lesser hyoid, all of which are related to cranial nerve 7. All right. And this guy, the stapes, is responsible for hyperacusis in any patient that comes and says everything is sounding way too loud. I don't know if you guys have ever seen this image, but this was something that was presented to me by my neuroanatomy teacher in med school, right? So this is the ear, but in a very nice systematic manner, where they're kind of showing it to you as a cube, in a sense, right? This is not that common of a picture. I haven't really been able to see this picture being used by almost anyone anywhere, but it is a thing. It is a thing. Kaplan had questions where they asked you questions in relation to this thing, and then you had to know whether it was the roof or the floor or the wall, any of that stuff. But it's a little weird because, you know, not many people are accustomed to this image. But one thing you want to keep in mind, though, is you can kind of use this image to really see how all the different nerves are responsible here. Right, so you can kind of see your facial nerve right here, right? It is going through your ear canal. It does go through your deeper ear, and there is a prominence of the facial canal right here, right, within the ear. So your cranial nerve is actually in there. Facial nerve, cranial nerve 7, is actually in there. You also have a tympanic branch of the glossopharyngeal nerve, cranial nerve 9, which is also in there, and it's actually on this thing called the promontory, right? Very few questions on that, but if you ever get a question where they're talking about cranial nerves and they're talking about the ear, and facial nerve doesn't seem to fit in, nor is it a question about cranial nerve 8 because it's not a vestibular schwannoma or anything, but something's happening and it's in relation to possibly the throat as well, that's when you pick glossopharyngeal nerve. Okay, this patient might have irritation of the throat, which leads to them hearing weird sounds. That is where you pick the glossopharyngeal nerve because it is in the anatomy of this cube. That same glossopharyngeal nerve also gives you your lesser petrosal nerve, which you might have heard of. Down here you have your chorda tympani, which came from here, right? So from the facial nerve, it goes across the ear, right? Comes out over here. All of this is then you can see in relation to your sympathetic plexus on the internal carotid artery. So there's a lot of stuff that can affect any of these nerves within the ear, and you can get silly questions on it. Just be ready. Just know there is some level of connection. It's not that there's no relation at all. You don't have to memorize this box, nor do you have to really pay a lot of attention to it, but it's a nice image. It's pretty cool, and you get to see how a lot of the nerves are flowing through the inner ear. Down here, this image is pretty relevant. This one you do have to know. So here what you're seeing is all the cranial nerves and how they're related to different parts over here and your ear. Right, so this one down here on the bottom portion of your ear, that's your greater auricular nerve coming from C2 and C3. Your lesser occipital nerve is the back portion of your ear. So all of that orange stuff, alright? In the front, you have your auriculotemporal, which comes from cranial nerve V3. It's a trigeminal thing, 5.3. Alright, so that's right here. Remember that although these are all cutaneous sensory innervation, your cranial nerve 5 is also responsible for muscles and mastication, and your cranial nerve 7, which is up here, this guy is also responsible for the muscles of the face and smiling, right? So they're both muscles that have sensory as well as motor innervation. The one thing on this image that is most clinically relevant, and they have trick questions on this, is the fact that in here, this purplish area, you have an auricular branch of cranial nerve 10. So how is that relevant? You might have seen a question where someone was like doing something in the ear and then the patient passed out, right? It might be a younger patient, it might be an older patient, but you might be doing something in the ear, maybe examining the ear or something, maybe cleaning your ear with a swab, and it caused the patient to just feel very, very hypotensive. That's because of relations to cranial nerve 10. Right? Vagus nerve is also responsible for stuff with the heart, and it has a lot of parasympathetics to it. Parasympathetic is rest and digest. You're going to get hypotensive when you activate your cranial nerve 10. So it is, in fact, possible to make a patient pass out because you were activating too many parasympathetics by actually caressing this part of the inner ear, right? Or middle ear, actually. No, sorry, this is all outer ear because you can see it. So this is all outer ear stuff, right? All of this is outer ear, you can see it. And in this portion of the outer ear, this purplish area, it's cranial nerve 10 innervated, and that stuff can make a patient pass out. So if you ever have a weird question where a patient passed out when you were doing some kind of ear exam, that's what they're talking about. Here you can see better the snail thing they were talking about with regards to your organ of Corti. Right, so this is your entire cochlea stuff, and then if you look in here, this is what this looks like. So they zoomed in on it, right? So this is the inner stuff of your cochlea. You have your big ass thing in here, inside in the middle portion. So the upper and lower portions, by the way, your scala vestibuli and scala tympani, those upper and lower portions are just full of fluid, right? So keep that in mind. In the middle, though, in the middle you have this empty air stuff. Right, you can see your nerves coming here, cochlear nerve. You have a bunch of cochlear nerves that come to the inner hair cell, and then a few that go deeper in and go to the outer hair cells. Right, inner and outer is named based off of inner being more medial, outer being more lateral. Okay, and all of them have these skinny little projections that are connected to the tectorial membrane. When the tectorial membrane moves back and forth, right, it brushes those hairs, and based off of that, this is how you send signals using the cochlear nerve fibers, and you convert all of that into actual sound. Right, so that's what you're seeing there. This is an AMBOSS question on the acoustic neuroma. So, an otherwise healthy 62-year-old woman comes to the physician because of a 3-year history of hearing loss. To test her hearing, the physician performs 2 tests. And now you know immediately they're going to be doing Weber and Rinne stuff. And these are images to better show you how Weber and Rinne stuff is done. Especially with the Rinne stuff, remember how to actually place it on the mastoid. They're showing you that in image 2. How to hold it without physical contact. They're showing you that in image 3. So this patient, the 62-year-old, you're about to do those tests on her. So let's see. To test her hearing, he performs 2 tests. First, a vibrating tuning fork is held against the mastoid bone of the patient and then near her ear, to which the patient responds she hears the sound better on both sides when the tuning fork is held near her ear. So that's a Rini test that's bilateral, right? So now we're thinking something sensory neural is happening. Next, the physician holds the tuning fork against the bridge of her forehead, to which the patient responds she hears the sound better on the right side. So she hears the sound better on the right side because of the physical contact. That means that the Weber test, remember the Weber test lateralizes to the unaffected ear? So the affected ear must be the left one. That means on the left ear she has some kind of sensory neural issue. And the patient's examination findings are more consistent with which of the following? It must be an acoustic neuroma, an actual nerve issue, sensory neural issue on the left. In this patient, the results of the Rini test are positive, indicating normal conductive hearing because she had better air conduction than bone on both ears. In combination with the Weber test that lateralized to the right, this indicates left-sided sensory neural hearing loss. Both ears are normal according to the Rini test here, and then the Weber test showed that the left ear cannot hear well, so there must be sensory neural deafness there. Acoustic neuromas, which commonly arise in the internal acoustic canal, often exert a mass effect on the vestibulocochlear nerve. The resulting unilateral sensory neural hearing loss, as seen in this patient, is the most common early symptom of this condition. Other symptoms include tinnitus due to pressure on cranial nerve 8, as well as dizziness, vertigo, and gait instability due to vestibular deficits. You can also have symptoms of compression of cranial nerve 7 or cranial nerve 5, as we saw, I think in the last video. Last time when we were talking about the last few things, we saw, no, it was 2 videos ago. So 2 videos ago we talked about brain tumors, and one of the things was your adult brain tumors, and you had the schwannoma. Was it the schwannoma, right? And you can see the acoustic schwannoma right here, right? This thing can occur within this triangle. It can get bigger and bigger, and within the triangle you can see you have your cranial nerve 7, cranial nerve 8, which you're actually getting the tumor in, and cranial nerve 5, right? All of them are within this cerebellopontine angle. So you can have compression of any of these nerves, leading to more and more symptoms. Okay, so don't get thrown off if you see some crazy extra symptoms. Here, I just talk a little more about the same 2 tests, the Rinne and Weber. You should be able to do it pretty well if you review this a couple of times. We've done practice questions for both scenarios. One where the Rinne test localizes to one ear, and we did questions where the Rinne test was normal in both ears, so then you do the Weber test after that to confirm what's happening. Look at the questions a couple more times in this video, and you should have a good idea of how to use the information from those 2 tests to diagnose a patient's hearing loss type. The last thing in otology is vertigo. Right? So vertigo is a pretty common thing. I've actually seen patients that came in with vertigo issues when I did my 3-month internal medicine rotation. So vertigo is a sensation of spinning while actually stationary. It's a subtype of dizziness, but it's distinct from lightheadedness, which is related to blood pressure. Peripheral vertigo is more common. It's an inner ear etiology regarding the semicircular canal debris, a vestibular nerve infection. It can also be Meniere's disease, which has a triad of sensory neural hearing loss, vertigo, tinnitus. All right. They wrote endolymphatic hydrops, where you have increased endolymph within the inner ear. And the last thing, it can also be BPPV, which is benign paroxysmal positional vertigo. Treatment is using antihistamines, anticholinergics, antiemetics, low salt diets, which no one ever listens to, and something called an Epley maneuver. Now, in my 2018 book, I used to have the whole Epley maneuver kind of described, but it was extra. If you really want to learn what the Epley maneuver is, you can kind of check it out. But in summary, the Epley maneuver is basically you tell the patient to lay down flat on, with their chest up, flat in the bed, and their head is kind of hanging, and then you sort of tilt their head in certain ways to get the semicircular canal debris to just keep moving within the canal and kind of get it to reach an end point and come out. Or I'm not entirely sure what they're trying to do with it, because if it goes to the end and just gets to the apex and gets stuck there, now what? But there's a maneuver. You kind of get your stuff inside the ear to move around, and you get it all out or something like that. It was weird, right? But it was regarding endolymph as well. So if we look at it, I wrote here BPPV is the most common. It's caused when calcium carbonate stones called otoliths break free and flow within the semicircular canals. You could test for this with the Dix-Hallpike maneuver, which is another maneuver similar to the Epley maneuver, where you do the same kind of movements of the head, and then because of where the otoliths might be getting stuck, the patient might just have vertigo even though they're just laying flat, So it's a weird thing. I don't really get the concept of those maneuvers because it doesn't really treat the patient, but treatment would involve somehow getting rid of those otoliths, getting rid of any kind of debris within the semicircular canal. Central vertigo is central, so it's related to the brain. So it's going to be a brainstem or cerebellar lesion. You're going to have a stroke affecting the vestibular nuclei or the posterior fossa tumor. Findings are directional or purely vertical nystagmus, skew deviation, where you have vertical misalignment of the eyes, diplopia, and dysmetria. You might have other focal neurologic findings as well, depending on the stroke and what it did. Okay. So up here we have a simple question on the same stuff. A 42-year-old woman comes to the office to discuss dizziness. She has a 6-month history of episodic bouts of a spinning sensation associated with nausea and ringing in her left ear. The patient also has difficulty hearing from her left ear, but her right ear is normal. The dizziness improves spontaneously and is fine between episodes. Past medical history has hypothyroidism, for which she's on levothyroxine, and endometriosis, which led to a hysterectomy at age 38. She does not use tobacco or alcohol. The condition is most likely a result of what? And the correct answer here was increased volume of endolymph in the inner ear, because this patient has Meniere's disease, right? She has sensory neural hearing loss, which they told you, in one ear. She has vertigo, and then she also had mentioned tinnitus. She said she has ringing in her ear. Right? So those three things together in the same question is a giveaway for Meniere's disease, which is related to peripheral vertigo. Right? Benign paroxysmal positional vertigo is going to be a patient who has vertigo when they try to bend over to pick up a box, or maybe when they're laying on a certain side of their bed, they start getting this sensation of vertigo. And vertigo often leads to vomiting too, so don't get too thrown off if they tell you that the patient started vomiting, which is why you have antiemetics as treatment here, right? Just for the symptomatic relief. Right? If the vertigo is really bad, this patient could be vomiting excessively. Right? So make sure now, after this is done now, make sure that you go back, review neuroanatomy tracts, review how they travel, what parts of the different parts of the brain they use, and then at the same time look at the pathologies of how different strokes, different arteries, different tumors can cause those tracts to not work, right? And then you get your medial medullary syndrome and all the other things that were on that page. Understand how those guys are all related to each other and master that, because you don't want to move on and pick up more things before actually having mastered that. So get that done today. That's definitely something that you can achieve very easily today. And then in the videos, I've already talked about all of that. And in my next video, I'll go on to another rather difficult topic with a lot of questions, ophthalmology.